Good afternoon. I've been asked to deliver grand rounds on COVID, and I think this is a very timely presentation. It's been a good time for me to review the literature, and I think we are now at a stage of pandemic mitigation, which is what I have titled this presentation. So in the next half an hour or so, I'm going to review what we've learned about the epidemiology and transmission of COVID in the last 10 months. I'm going to review the clinical features and allude to some advances in treatment. And then I'll finish off with the burning questions for everybody, which is immunity and vaccination. And very importantly, this talk is dated the 18th of September because I'm conscious that in 2 weeks' time, this talk could be completely obsolete. So in Ireland at the moment, unfortunately, we do seem to have a resurgence of COVID. So if we look here at data from the HPSC, to date, we've had just over 31,000 diagnosed cases with nearly 1,800 deaths with a mortality rate of 5.8%, likely reflecting the fact that at least initially in the pandemic, testing was really reserved for those who are symptomatic and quite unwell. And we can see in early March, there was a huge upswing in cases. And then with social distancing and flattening the curve and all the lockdown, the epidemic in Ireland was brought in under control. We seem to do well pretty much for the early summer. And really since August, rates have been increasing to an extent now that our doubling rate is about 10 to 14 days. If we look at the number of cases to date by county, we can see that there actually is quite a disparity in rates. So these are cumulative rates to date. And not surprisingly, the rates are highest in Dublin and the surrounding Dublin areas where population density is at its highest. The lowest counties to date have been Galway, Wexford and Waterford. Similarly, the cumulative rates have increased with age. Again, this likely reflects testing bias, as more recently the mean and median age of newly diagnosed cases are in their 30s. However, we can see that to date there has been a preponderance of cases diagnosed in patients in their 80s. So currently what's going on? So what we're seeing in Ireland with the initial flattening of the spring curve and then an upswing again, is very much reflected across Europe. We can see in Ireland that we know our overall rate is approximately, so the new incidence rate in the last 14 days is approximately 50 new cases per 100,000 population. This is significantly higher in Dublin, particularly in the southeast and in the northwest, where it exceeds 100 per 100,000 cases, and is significantly lower around the country, although you can see with this sort of color-coded regional map here that there are significant hotspots, including Dublin, notably Waterford, Limerick, and North Donegal. In Europe, similarly, there is quite a wide variation in cases, with Spain again leading the way, having in excess of 200 new cases per 100,000 in the previous 14 days. France is a little bit less, having just under 120 cases per 100,000. And you can see in Ireland, we are actually, although our rates are significantly increasing, we are still lower than mainland Europe. And again, you get the idea of hotspots around densely populated areas. So what have we learned about transmission in the last 10 months? So we know that following somebody ingesting the bat in Wuhan, subsequent transmission is person to person. And really the profile of the infection best fits droplet transmission. So this is an infection that's transmitted by droplets that I'm emanating now as I'm speaking, that are greater than 5 micrograms in size. They're relatively heavy, so they drop to the ground with gravity. So they don't travel more than 6 feet. When they drop down, they can live on surfaces as fomites, and this corresponds to that RO number of 2.5. So that for every person infected, the likelihood is that they will, without interventions being in place, they will infect 2.5 other people. There are concerns that it may also be airborne, and airborne means that it's aerosolized as we speak, and I'll talk about choir practice maybe as we sing, and the droplets are much smaller, so they can remain suspended in air. And the sort of prototype infection for this is measles or chickenpox, and the RO number is much higher. So the average person with measles will infect 18 other non-immune people. Saying that, as I say, for the most part, it does seem that droplet transmission is the main route of transmission. The risk factors for droplet transmission are people being close together, so within that 6 feet. If they're together for a prolonged period of time, and I know arbitrarily 15 minutes has been put as the length of time to be classified as a close contact. However, basically, the longer that people are together, the more likelihood of transmission. And then absence of ventilation, so indoors, closed windows, all being risk factors for transmission. And this was highlighted in one of the first reports of a close contact outbreak. This was a choir practice. There were 60 people at the choir, well actually 61. One unfortunately had URI type symptoms that was subsequently diagnosed as COVID, and over 50 of their co-choir members had secondary infection, with 3 people requiring hospitalization and 2 people dying. And in fact, these people were together singing for 2.5 hours. They moved places throughout the choir setup during that time. They stacked the chairs at the end. They had a lunch break, so there was quite an amount of mingling. Probably, as I say, the close contact, the duration, and moving around, accounting for the degree of secondary infection. So what are the high risk activities? And it's really being a household member. So for every household member diagnosed with COVID, there is an actuarial risk of 1/3 of their household contacts having COVID. So 1 in 3 household contacts acquire secondary infection. On the next tier down of infection are healthcare settings, congregate living settings such as nursing homes, prisons, homeless shelters, workplaces where people are very much together and can't observe social distancing, family gatherings, as has been in the media, travel, and then pubs. And it's estimated if somebody is in a restaurant having a meal with friends and they have COVID, the likelihood of acquisition, if you're sitting at a table with that person, is somewhere between 6 and 10%. And then low risk activities are outside, passing somebody on the street, or handling something. So again, there's been very rare, if any, documentations of transmissions purely from a fomite, from surfaces. So one of the big things that we've learned about COVID in the last 10 months is the issue of asymptomatic spread. And this is one of the things that makes containment of the infection extremely difficult. So this article in Annals of Internal Medicine compiled the outbreaks to date where asymptomatic carriage of the virus was documented. And some of these were a once-off testing, which creates the possibility that the patients were pre-symptomatic, that they may have developed symptoms in the following few days, and a few of them were longitudinal, so that they followed these people and did repeat testing and confirmed that they were positive without the development of symptoms. So the most notable of these, the first being the cruise ship, the Diamond Princess, which you all may remember back in February. In that outbreak, 46% of those who were COVID swab positive or PCR positive were asymptomatic. So again, this was the first time that the issue of asymptomatic infection was recognized. Subsequently, there have been even groups that have had a higher rate of asymptomatic infection. In a homeless shelter in Boston, close to 90% of those screened were positive without symptoms. And in a series of prisons, federal prisons in the US, 96% of those screened were asymptomatic. And actually, the hypothesis in this publication is that actually another beta coronavirus had been circulating in the previous 6 months, and they wonder, could there be some degree of cross-infection with prior infection. Now, obviously, the inmates of a prison tend to be younger, and many of them are relatively healthy, and this may in itself account for why there was such a high rate of asymptomatic infection. I also note here that a study I'm going to be talking about in a few minutes in a nursing home, very few of the occupants had asymptomatic carriage. So the majority of those who were infected had symptoms, with only 6% or 3 individuals having asymptomatic carriage. So what we know about asymptomatic spread is that up to 45% of those who are infected have no symptoms. There is some data that they may transmit the infection for longer, so they may remain infectious for longer. Most people with clinical infection are, we believe, infectious for about 48 hours prior to symptoms and rarely transmit after 7 days of symptoms. Those with asymptomatic spread are more likely to be younger. There are more women. And it really has opened up the paradigm for the need of broad testing, that we cannot exclude infection on the basis of symptoms. And it also provides the basis for mask use, as I'm going to discuss. So with the knowledge of transmission that we've gained in the last 8 months, what do we know about prevention and how can we prevent infection? So the first thing that we do know is social distancing, and the WHO recommends 1 meter between individuals. Again, based on droplet transmission, the CDC recommends 2 meters. And if we look back again at the epidemiological curves from the pandemic so far in Europe, we can see that with lockdown and with draconian social distancing, the rates came down. As we've laxed off on our social distancing, the rates have gone up. And this graph illustrates a compilation of studies looking at the effect of distance and infection with coronaviruses, including the original SARS, MERS, and now COVID. And if you take the average person who is at a high rate of acquisition of infection in these studies, the further they were, the less infection or secondary infection occurred. So we can see at 1 meter, it was decreased by close to 50%. However, 2 meters was better. So not surprisingly, the further people are away from each other, the less chance there is of these droplets to spread from one person to another. Now, what about masks? I'm going to be talking about masks in the next slide, but masks are indicated where social distancing is not possible. And although in February, it wasn't clear to us that masks were protective, they definitely are protective. And they do seem to be available, which was one of the other big concerns back in February, that we needed to reserve masks for healthcare workers and for hospitals. So prevention relies on social distancing, masks, individuals recognizing that they have symptoms and self-isolating. Hand hygiene is very important, as is cough etiquette, although one could argue if somebody is coughing that they should be self-isolating and not out and about. So this is the study looking at the utility of masks and eye protection in addition to physical distancing. It was a systemic review published in The Lancet in July, and they did a meta-analysis on a relatively small number of studies that were contained in the review that they felt were comparable. And just to summarize their data, because it's quite a dense paper, in terms of physical distance, they found that when people were close together, so first of all, I suppose there's no randomized controlled trials. So these are all observational studies, again, looking at a variety of coronaviruses, not just COVID-19. But if people were close together, the risk of infection was close to 13%. If they were distanced more than a meter, it fell to 2.6%. So nearly a 70% risk reduction. No face mask, they estimated risk of infection at 17%, with a face mask 3%. So again, face masks do not offer absolute protection, but a significant decrease, again, approximately 2/3 reduction in risk, and a similar effect seen with eye protection. And again, in some of these studies, the participants had masks and eye protection. In some, they had one or another. And regarding physical distancing, they are proponents of the 1 meter physical distance with that large 70% reduction in risk of transmission. However, they also comment that for every 1 meter further away in distancing, the effect can increase by 2. So that the further away, the better. So where are we with masks? Well, there is sort of clusters and outbreaks suggesting the protective effect of masks now that masks have been taken on board and are recommended. So this was an outbreak from Springfield, Missouri, in hairdressers. 2 hairstylists, one had been symptomatic for 10 days and the second became symptomatic, prompting the test and the recognition of her colleague who was originally symptomatic. During the time that both of them were estimated to be infected with COVID, they had 139 clients through the hair salon. Throughout all of this, the hairdressers themselves wore masks and all their clients wore masks. And there were no symptomatic cases of COVID. 67 of the 139 clients were screened and all were negative. So the CDC are very much reporting this, and they've put this poster together suggesting that while it's obviously observational, that it does suggest in a very close confined, poorly ventilated setting that mask use may prevent transmission. There is also a theory going around at the moment, which is theoretical, like most theories, that masks may prevent severity of infection and that mask use may actually be increasing in situations where it's not preventing transmission, it's increasing the rates of asymptomatic infection. And this gets back to this variolation. So what we know from smallpox is that, and chickenpox, is that if people are infected with a large inoculum, they get very sick. If they're infected with a small inoculum, they can have an attenuated course of infection. And this was back to smallpox, where kids were injected with a small amount of the virus to try and precipitate or lead to a attenuated course of infection. And it has been hypothesized that mask use may reduce infection, but in cases where infection occurs with mask use, that infection may be milder. So these are the risks for infection. What are the risks for severity, for disease? And the biggest thing that's been noted from the onset and first reports in China were age. So the age, the severity of disease is proportional to age. So this is from nature.com, looking at various countries and their reports. We can see in Geneva, the fatality rate for the over 65s was 5.6 times that of the baseline, the younger population. And you can see in the under 19s, there were no deaths. Similarly, in England, they have had quite a large or high mortality rate, 11.6 in the over 75s. And in Spain, mortality rate a little bit less, but again, declining with age. For whatever reason, we don't know, but men seem to succumb more with a twice a mortality rate to that of women. And again, that increases with age. One of the studies that is I suppose the most comprehensive and gives us the most information is this Open Safely study performed in the NHS, where they linked more than 10 million GP health records with COVID deaths, with nearly 11,000 COVID deaths, and looked at risk factors for mortality. So like the previous slide, again, concurred with age over 80 essentially having an exponential increase in mortality compared with younger ages. And you can see it on this figure. And I know the writing is very small, but I'll try and guide you through it because I think it really gives us a lot of information in terms of risk factor for mortality. So regarding age, they used the age group 50 to 59 as their reference range. mortality significantly lower in the 40 to 49 group. And then with each decade, we can see a significant increase in mortality rate, such that it's more than tenfold for the over 80s. Mortality rate in men to women was about 2 to 1. Mortality rate increased with obesity, with BMI over 40 having the highest mortality rate as here. Again, ethnicity has been shown, so non-white Caucasian ethnicity has been shown to be associated with poorer outcomes, and they showed mortality rates of approximately twice that in Asian, Black and mixed race compared to whites. In the study, they also saw higher mortality associated with deprivation. And it was interesting because it was such a huge study, they were able to control for comorbidities and obesity. So the deprivation scale, based on where people lived, was statistically significant, even controlling for all the covariates. Diabetes was shown to have about a twice mortality rate. Cancer was interesting. Non-hematological cancers in the first year of diagnosis, patients with COVID had twice the mortality rate. However, after the first year, it decreased significantly and returned to baseline mortality rate for age and sex if cancer was 5 or more years ago, which I think is very reassuring for cancer survivors. And the same pattern with maybe a higher attributable mortality was seen in hematological malignancies. Reduced renal function, again, was associated with a higher mortality rate, and it was proportional to the degree of decrease in renal function. Asthma, one of the things that was initially touted to be associated with a worse mortality rate, really isn't coming through as a marker and as a concern, which will be very reassuring to a large population of people. Chronic respiratory diseases, though, is. Cardiac diseases to a lesser effect, and then liver disease, neurological diseases also being associated with higher mortality, as is organ transplant. I just want to put here, because this is a source of calls for many of our patients, but rheumatoid arthritis, lupus, or psoriasis is associated with a relatively small increase in mortality that really is less than the increase in mortality associated with sex. So I think this figure to me really outlines in the most detail who are the patient groups that we need most to worry about in the setting of COVID acquisition. So as I say, the predictors of disease are age, sex, and underlying health. And there's this whole interplay between chronic diseases, obesity, and social determinants of health. So ethnicity, socioeconomic status, and sort of the social and community context that is very difficult to model for, but is very much determining a pattern across many countries of hotspots of significant COVID disease. So the biggest thing really, as we potentially head into another curtailment of activities, and the biggest activity, I think, so from a societal perspective that we have to consider is schools and colleges. And if we just look for 1 minute at children versus the elderly. So this is a study published in the MMWR, 14 states in the US from March to July, looking at COVID infection in children. So 208 children in these 14 states required hospitalization, which is a relatively small number given the millions of population. 1 child alone died from COVID during that time in these many states. And if we compare this to one outbreak, one of the first outbreaks that was reported in a nursing home in Kings County in Seattle, we can see that there were 101 residents infected in the nursing home, and there was a 33% mortality rate. So in one nursing home, 34 people died. So the discrepancy in mortality outcomes for children versus the elderly is quite stark, and it's really like two different illnesses. And this is data from the HPSC, and we can see to date in Ireland there have been no deaths from COVID in the under 14s. There has been 1 death in the under 24s, and to my knowledge, that individual had comorbidities. So the final thing that I think we need to think about as we move into this resurgence is healthcare capacity. So we can talk about how we prevent infection, how we prevent disease, but how do we best care for patients? And it's been shown, and this was probably one of the oldest studies, an old study now being 7 months old, um, from Hubei compared to other provinces, Wuhan's and Hubei, they had the most number of cases and they also had the highest mortality rate. So they basically, across Hubei and other provinces, they plotted number of cases by mortality rate, and really you can see from this graph that the more cases there are in general, the higher the mortality rate. And this has come through from London and New York and Northern Italy, where healthcare settings are overwhelmed, mortality rates increase. And we need our ICU capacity, but we need everybody who works in an ICU to be trained and have experience in working in ICU. So what do we know about the clinical illness? So as stated, we increasingly realize that maybe the majority of people infected with COVID are asymptomatic. Of those who develop symptoms, 81% have mild symptoms, so no or a mild pneumonia. 14% are severe and 5% have critical disease requiring ICU support. And we are using in our unit for severe infection or severe disease, we are using the IDSA definition, which is O2 sats less than 94% on room air. So requiring oxygen to keep sats at 94% or above. So again, early on in the pandemic, it was recognized that this is a biphasic illness. And again, this makes caring for patients quite hard, because initially when somebody presents with symptoms, if they're early in the course, they have a positive test, it's hard to know how they are going to do. So for the first 7 to 8 days, the predominant symptoms are fever and cough. And our experience has been fever, and the people who progress on are the people with daily fevers. Approximately day 9 of their illness, they deteriorate and require oxygen, develop infiltrates, progress to ARDS, and then potentially to other organ failure and requiring ICU support. This study was compared the clinical course of survivors and non-survivors, and you can see in this pre-ARDS phase, there really is no difference between the survivors and non-survivors. So in that first 7 or 8 days, you can't predict who's going to require further support. And this is important as we get to talk about treatments. Predictors, as we said, the main predictor is age, SOFA score, and then D-dimers has been the one blood test that's been shown in several studies. If the D-dimer is greater than 1,000, is associated with a poor prognosis. So just to review 2 cases, the first case is a 42-year-old Irish man. He had a BMI of 35. He presented to the hospital after 7 days of a febrile illness with acute onset shortness of breath. At presentation to ED, his temperature was 38.5. He immediately required oxygen. In fact, his sats were 90% on 4 litres as he came through the door. And he very rapidly deteriorated, requiring intubation, mechanical ventilation, and transfer to ICU. And you can see he's got diffuse infiltrates consistent with ARDS. Over the first 24 hours of his hospitalization, his CRP increased from 105 to 438. He went into acute renal failure requiring dialysis, and his ferritin was extremely high. He was intubated and ventilated for 2 weeks. He was dialyzed for approximately 3 weeks, and he ultimately made a full recovery and is now back to normal health. In fact, 2 weeks following discharge, he was up a ladder painting his house. A very different spectrum of infection was a patient who presented in the same week. So this was back in March, a 51-year-old African male who presented to ED with chest pain. He had a slightly elevated BMI at 32. He also had comorbidities. And because of his chest pain, his inflammatory markers were mildly elevated. Because of his chest pain, he did CTPA done that shows these ground glass peripheral opacities, very suggestive of COVID. His COVID screen was positive. He was observed in hospital for 3 or 4 days. His SAT remained stable. He was afebrile. He never required oxygen, and he was discharged well, somewhat wondering what all the fuss was about. So we can see two very different presentations and clinical courses. And that's what makes COVID so challenging in terms of trying to provide care. And obviously there are all the flags that I've already discussed: age, comorbidities, ethnicity, symptoms of presentation. My clinical experience to date has been that it is the persistent fevers that is the marker, or should sound the warning bells, that this person could potentially run into trouble around day 7 or day 8 of their illness. And then when they do run into trouble, it's with ARDS and multi-organ failure. And the ARDS seems to be due to an intravascular coagulopathy, and the treatment is supportive, although there does seem to be a role for dexamethasone. I'm going to discuss that in a minute. And then the prognostic factors, we've discussed D-dimers. High ferritin, in our experience, has also been shown to predict a poor prognosis and to nearly predict who may ultimately require oxygen support. So the big thing in terms of treatment developments has been dexamethasone. So many of you may have heard of this, the recovery study published in the New England Journal, and really was a remarkable study undertaken in the NHS, where over 6,000 patients were randomized on a 2-to-1 ratio to usual care dexamethasone. And in the group that got dexamethasone, mortality rate was reduced by 17%. So usual care, the 4,000 who were treated as per usual care had a mortality rate of close to 26% and reduced to 23% in those given dexamethasone. And this was 10 days of 6 milligrams dexamethasone, IV or orally, for the duration of their stay, or up to 10 days. So I suppose the little graphic here, the little diamond showing a reduction in mortality with dexamethasone. They then did a subgroup analysis, and they found that the benefit was most in those patients who required invasive mechanical ventilation at the time they were randomized, where the mortality rate reduced from 41 to 29%. There was also a significant benefit for those patients requiring oxygen, again, a reduction in mortality from 26 to 23%. But in patients who did not require oxygen, there was no improvement in mortality, and there may have even been a suggestion that mortality was increased, although that was not statistically significant. So it does seem that the use of dexamethasone is in those patients who are entering that ARDS phase as an anti-inflammatory. And it is now recommended by the Infectious Disease Society of America, and I believe the HSE are working on guidelines recommending dexamethasone use in patients with COVID requiring oxygen. So remdesivir is an antiviral. It was developed during the original SARS. It has been extensively looked at with ongoing studies in COVID. And unfortunately, so far, it has not been shown to reduce mortality. There's been 2 big studies published. There's been other studies done that were terminated, and there are ongoing studies. And in the first study, in the New England Journal study, the patients randomized to remdesivir had a shortened time to recovery, but no reduction in mortality. And a subsequent study conducted and sponsored by Gilead showed that people randomized to a 5-day course of remdesivir had a significantly better clinical status compared to those who did not get remdesivir. But again, the importance of this was not clear, and there was no difference in mortality. Now, one of the comments has been, and both these studies have triggered an avalanche of of correspondence and letters in the journals in which they were published is that maybe the timing is wrong. And the average time in the New England Journal paper to randomization with remdesivir was day 9. And it may be that in this early viral phase is when we should be using antivirals such as remdesivir. And we do know that in the subsequent ARDS phase is when there is the most benefit with dexamethasone. So it may be that we need to think more pathophysiologically in prioritizing these treatments and also in designing the clinical studies. Obviously, there's been a huge media coverage of treatments, but unfortunately, all of these hydroxychloroquine, azithromycin, Kaletra, and ivermectin to date have not been shown to be useful in COVID. What we do know, and what many of our colleagues have said from the beginning of the pandemic, is that we need to enroll patients in clinical studies, because we have to learn from this, and we have to make sure that we are not affected by our own bias. So the Solidarity trial is a WHO sponsored trial. You can see it is a truly worldwide study, and it is designed to be a evolving study where that new treatments can enter the protocols or be removed from the protocols, as long as there is an equipoise of perspective as to their efficacy. So currently remdesivir is part of the Solidarity trial. Galway is a site for Solidarity, and in fact we enrolled our first patient today, as we had our first admission with oxygen requirement and severe COVID since May. So non-pharmacological interventions have also been looked at. There is a suggestion that non-invasive ventilation has a role and may prevent mechanical ventilation, and that is a step in the management that we did not predict back in February. The other thing is proning, and obviously in the ICU, proning in mechanically ventilated patients has been long used in ARDS as a method of recruitment of lung function. In COVID, we are now looking at awake proning, and we have been doing this, and our ICU are involved in a study looking at awake proning in COVID patients. And basically this is lying on your tummy for up to 8 hours. And at least initially, it does seem to improve oxygen requirements. As to whether it changes the natural history of the infection remains to be seen, and will only be proven by studies. So as healthcare workers working in Galway University Hospital, what do we need to consider? So at the moment, we are screening all admissions, and we're screening pre-op patients. So nearly every patient you see in the hospital will have a COVID swab done, and the vast majority of those will be negative. Saying that, what we have learned about COVID testing is that there is a need for serial testing. People with negative tests can be in the incubation period and can still develop clinical COVID. So in patients who develop a fever, there is a need to repeat the test, even if they've had an admission negative test. We do need to wear masks in all areas, and that this week has been further defined as in corridors, lobbies, canteens, and we need to use the appropriate PPE and be experienced in donning and doffing. It is very important for all of us that if we are unwell, to stay home, not to come to work. And I know nurses and doctors have a long track record of working when unwell, and we need to contact Doc Health. And ID has put a huge amount of work into our testing clinic to facilitate quick turnaround testing, combined with Micro, who have put a huge amount of work into ramping up testing capacity and turnaround. And we also, as individuals, have a responsibility to social distance and adhere to the rules. And I've just put the rules up there, and I'm not going to go through them. So getting back to our current strategies to control COVID, and realizing that we are in the midst of a resurgence, it does seem that the big issue that is difficult for us to deal with is the issue of asymptomatic transmission. And this has led to uh, the use of testing as a control strategy. So in an ideal world, and I'm sure Professor Cormac and Anuni Rian will not agree with me, but in an ideal world, if we could all wake up every morning, do a COVID test. If our COVID test was positive, we'd stay home and self-isolate for 14 days if we've no symptoms, or 10 days if we've symptoms. If our COVID test was negative, we could happily go to work. And it has been said that everybody who surrounds Trump is tested for COVID daily to ensure that he can go about his life shaking hands, not wearing masks, hugging people, and whatever else he does. So testing can nearly be seen as a dam or a barrier to keep COVID out. And this serial testing as a control strategy has been introduced both in Ireland and internationally in congregate settings where social distancing is not possible and where outbreaks have had an extremely high attack rate. So these include nursing homes, direct provision, meat packing plants. And the question would be, if rates increase and there are more outbreaks within hospitals, whether we should be serially testing within hospitals for both patients and healthcare workers. One of the issues that people are grappling with around the world is colleges going back and schools going back, and particularly in the US, where colleges are congregate settings and people live on campus, and there is a huge financial impetus to keeping colleges open. There's been a lot of studies looking at frequent rapid turnaround testing and using tests that may have a lower sensitivity. So this is one study published, and it's a modeling study, and it's looking at a hypothetical college campus with 5,000 students who are engaging in social distancing. And they basically found that if they did a COVID test every 2 days with a test that wasn't brilliant, had a sensitivity of 70%, at any one time out of their 5,000 students, they would have 116 students isolated, and they would have approximately 21 students with a true positive result. But that with this serial testing, they could potentially ring fence or protect their core activities and the majority of their students. And this was actually done, and I've just taken this cartoon from the New York Times. This was done in summer camps in the US, in several summer camps, where the kids starting summer camps self-isolated for 14 days. They were tested on arrival at the summer camp and were isolated until their test came back negative. And then they were tested every 2 weeks for the duration of summer camp. And while there were small outbreaks seen, the majority of these camps were able to stay open, and these kids were able to have a normal teenage experience. So while I'm not necessarily advocating this now, I do think that as COVID evolves, that we need to start looking at testing as a way to protect us and not just as a way to identify people who are positive. So the last thing I'm going to talk about is immune response. So I suppose the good news, and this is a good news slide, is that the infection does seem to elicit a normal immune response. So it elicits both a cellular immune response with CD4 and CD8 cells. It elicits a humoral immune response with IgM initially, and then IgG antibodies being determined. And this second part of this graphic, whether there's an amnesic response, is really the question that remains to be asked. So there have been several studies and observations made that suggest that there is at least a somewhat sustained immunity to COVID. So the first of these is a study in primates, in rhesus macaques, and looking at a model of SARS where the macaques were infected with SARS, they developed COVID infection, they recovered, and 28 days later they were reinfected, and none of the primates developed a second symptomatic infection. So at least at a primate level, over a relatively short period of time, so a month, suggests that there is sustainable or sustained immunity. Now, one of the issues that has been posed is that the antibody levels can decline quite rapidly. And a study published in the New England Journal this week from Iceland suggests that in those who mount a humoral immune response, so who develop IgG, that over 4 months, those IgG levels remain robust. And again, they suggest that it does seem that at least over a 4-month period of time, that immunity is sustained. I think the study that I remember, and many of you will, I think, probably recall following this lecture, is a outbreak report from Seattle. So this was an offshore fishing vessel with 120 fishermen who boarded in Seattle. Their plan was to be at sea for 32 days. And as part of a public health initiative, they were screened by both PCR to ensure they were PCR negative as they boarded the ship, and they were also offered antibody testing, which they all agreed to. Showing that there are limitations with once-off PCR COVID testing, there actually 12 days out at sea, there was an outbreak of COVID on the vessel. Of the 120, 107 developed COVID. And when they looked back at the baseline serology, 3 of the original 120 were seropositive. So they had prior infection prior to getting onto the boat, and none of them developed COVID. 107, so a huge attack rate of 117 who were initially seronegative, developed clinical infection. Unfortunately, though, particularly in the west of Ireland, there is a very small proportion of our population that has been exposed. We have a very low seropositivity rate, and we are nowhere near herd immunity, which short of vaccine was the only other thing that will prevent transmission. So this is the SCOPY study. It was conducted by the HSE in Dublin and in Sligo, where they did random selection of nearly 2,000 patients or 2,000 people in the community with a blood sample and questionnaire. In the Dublin area, there was a 3.1% seropositivity, and in Sligo, not surprisingly, given a much less dense population, the seropositivity was 0.6%. So even in Dublin, where the rate all along of COVID infection has been much higher, we are nowhere near the level of protection that will be required. So this leads us to vaccines. So there are 9 phase 3 clinical trials of vaccines. I think it is unlikely, and was in the Guardian this morning, it is unlikely that there will be a vaccine before this time next year that will be widely available. The 2 leading runners are the University of Oxford partnership with AstraZeneca. It is an adjunct boosted vaccine that requires 1 dose. The second leader in the race seems to be the US Moderna vaccine, which is an mRNA vaccine and requires 2 doses. So obviously there's double the logistical issues for the second vaccine. It was widely reported that the University of Oxford study was interrupted this month with 1 serious adverse event. However, it does seem that it is back on track. And really, from the point of view of the next year, the vaccines are the light at the end of the tunnel. They are what will reduce transmission of COVID in our community. So in summary, it's a little bit depressing. There is undoubtedly a resurgence of COVID, and I think it's here to stay. I think it's unlikely that we're going to be able to do the lockdown to the degree that we did in March and April to reduce the curve. So we need to focus on several things. So one is, how do we prevent infection? And we prevent infection by social distancing, by wearing masks, by hand hygiene, and by rapid turnaround, easy to access, test and trace. Preventing disease is a little bit different. To prevent disease, we need to reduce infection in the over 60s and in people with underlying illnesses, including high BMI. We do have some new treatments, notably dexamethasone, for those patients requiring oxygen. We know that we can use NIV, proning, and then we need to make sure that we maintain our ICU in capacity. And as I say, the really only good news at the moment is there is emerging evidence of sustained immunity, which suggests that when vaccines are available, that they will, at least for some time period, be effective. So just to finish with a meme of one of the few books that I have read over 100 times, this is where I am at the moment with COVID. Thank you.